I work with a group called TRIO, which I talked about earlier. And so this is a presentation looking at the utilization and effectiveness of Cabotegravir and Rilpivirine in patients who are viremic at initiation. We wanted to take some of the work that was done at UCSF by Monica Gandhi and look at it in our cohort and see what we could find. These are my disclosures. Background I'll go through quickly. We know that CAB and RPV is used for treatment. It's intended, however, for people who are suppressed. The rationale for that may have been nobody knew what the effectiveness would be in viremic patients, and so it was not intended to be used that way. However, clinicians would sometimes imagine that, use things off-label, and in this case, our clinicians did, as well as many clinicians in San Francisco. So we looked at this group, and I want to make a distinction between the time periods. There was an optional lead-in, which I think virtually nobody did. Then the initiation injections were injection 1 and 2, so they were 30 days apart, and then the continuation injections. So when we talk about adherence and persistence, because one of the points of our analysis was to look at people who had proven to be non-adherent because they were viremic on previous regimens, how adherent would they be to this regimen? The study objectives were to evaluate utilization of CAB and RPV among this population, with the detectable viral load being greater than 50. We chose to use a stringent, not a 200 copy, as we do in larger studies, but in this one we used greater than 50, and look at adherence, persistence, and effectiveness. Methods. The data was from our sites throughout 14 geographically distributed FQHCs. These sites are geographically balanced for the most part in terms of the demographics in the U.S. The inclusion criteria are as listed below. Viral loads were greater than 50, and the exclusion was any participation in a clinical trial. The study outcomes were looking at persistence. We defined that as remaining on CAB-RPV. Discontinuation was established as 2 injection cycles. We were very rigorous in our analysis in that we didn't go from prescription data. We looked at procedure codes, and we wanted to look and see when we saw that, not based on any notes, when there were two missed doses. Effectiveness, as I said, was less than 50, and genotypes, we had that in about 45%, and I'll show you that data in a second. Results. The study population, we started with 70,000 patients. We cut down to a little under 1,400, 1,355, who had more than 1 injection on CAB-RPV. About a little under 10% of them were patients who were viremic on entry. 57 had viral loads between 50 and 200. 54 had viral loads greater than 200. The characteristics I listed, you can see some of the things circled in red. I'm not going to go through this. We did have about a third of the patients had BMIs greater than 30. And I want to point out the distinction between greater than 30 and how much greater than 30 when we look at evidence, because we can talk about that in the Q&A. I won't have time. You can see about 28% had 30 to 40, and about 4% had greater than 40. Viral load copies, you can see the distribution here. Treatment history, the vast majority had been on INSTIs prior to entering CAB-RPV. 90%, they had frequently, 95% had been on nukes, about 20%, 22% had been on NRTIs. Big TAF represented about half of the regimens overall, 54%, and we had genotypes on 40%. Of those groups, the ones we had genotypes, none of them on entry had INSTI RAMs, and you can see that NNTR RAMs made up about 18% overall, and there's the breakdown for the low-level and high-level viremic patients. Looking at persistence. So median follow-up after the first injection was 9 months. 81% of the subjects stayed on CAB-RPV till the end of follow-up, and 86% we had 6 months follow-up, 74 12 months. Persistence at 6 and 12 months was higher in the low-level viremic group. No injection site reactions were observed in any of the codes. The codes aren't a great way to note ICD-10 codes, note injection reactions, so I wouldn't put too much credibility in that. Discontinuation. 19% of the patients met the discontinuation outcomes. The median time to discontinuation was 7 months. Of them, 10% reinitiated CAB-RPV within 6 months. 19% were lost to follow-up at the last injection. Of 17 with follow-up viral loads, 77% had a viral load less than 50 prior to discontinuation. Adherence. Adherence, the injections were, for the most part, well adhered to. This was surprising when we looked at it because we would have thought this group was prone and prejudiced. It was a selection bias to enter people, but in fact, they did pretty good. Maybe people learn. That would be an optimistic thing these days to think people learn, but maybe people learn. And so 95% had their second injection on time. Of 86 with continuation injections, 36% had a delay, but the delay was less than a week. So for the most part, it was pretty good. No missed overall injections were identified. Effectiveness, I know you were waiting for this. 73% of the patients had at least one viral load. We had an 89% rate of follow-up. This is across different sites, so it's not a protocol. It's just what we're seeing in clinical practice. A higher proportion of the suppressed patients identified in low-level viremia, 93% versus 84%. And suppression occurred at a median time of about 3 months. All individuals, even with low-level viremia, had viral loads less than 200, which in some studies is considered aviremic, and 84% of the high-level viremia group had a last viral load of less than 200. Confirmed virologic failure after suppression, we had 2 patients out of the 111, surprisingly low. I listed both cases here. The no genotypes were available for the first case, and the second case had baseline RAMs of that you see 179D, emergent RPV resistant, and surprisingly, no emergent INSTI RAMs were identified. Limitations. Reasons for discontinuation, very difficult to say in real-world evidence. You're dependent on ICD-10 codes because we didn't use structured data, so we couldn't tell, unstructured data, so we couldn't tell any kind of text-based reasons, so I don't think we really can comment on that. Individuals could have been lost to follow-up at the different clinics, that is one, and for individuals who discontinued it and reinitiated, we don't know always if oral bridging was utilized, if it wasn't listed, because we can't trust prescription data in real-world evidence. We learned we have to see dispensers, and not all of those sites had dispensers, so we just didn't comment on it. Conclusions. The majority of people on CAB-RPV achieved virologic suppression and remained suppressed. 84% had viral loads less than 50 copies. People with baseline viremia demonstrated good adherence. No missed injections were observed. The majority were fully adherent. High persistence was observed with 81%. I'll make my quick. Do I have another minute? Am I out of time? Or I'm taking a minute anyway. When I saw the data as a clinician from San Francisco, I just thought, well, that's because they have unbelievable social connections and milieu, because that's what they do in San Francisco. Patients get more care than they get at 14 sites. In fact, our 14 sites, which were all over the country, had almost similar results to the study in San Francisco. So I think that's notable for me. Thank you for your time.